You're listening to Conferences Online Allergy from Children's Mercy Hospitals and Clinics in Kansas City, Missouri. Today is July 23, 2012, and I'm your host, Dr. Jay Portnoy. Our topic today, urticaria and angioedema. Our presenter is Dr. David Lang. He's the Allergy Immunology Program Director at the Cleveland Clinic in Cleveland, Ohio.
That's okay. So, Jay, you're in a conference room with a number of people, including your fellows, I assume?
Absolutely.
Okay, well, I can't see you and you can't see me, but your fellows, may I ask them to introduce themselves?
Certainly. Why don't we go around, and if you'd like, we can, so why don't you start, Monica?
Sure. My name is Monica Gerner. I'm one of the first-year fellows.
Hi, Monica.
Second-year fellow.
I'm sorry, what was the second person?
Nikita Raji.
Nikita Raji. She's a second-year fellow.
Nikita, okay.
We're on the table. Okay, go ahead.
My name is Aditi. I'm a fourth-year medical student.
Okay.
My name is Tara Federley. I'm one of the second-year allergy fellows.
What's your name, I'm sorry?
Tara Federley.
Tara?
Tara Federley, yeah.
Okay.
I'm Sunana Argo, one of the other second-year fellows.
I'm having trouble. Your first name is?
Sunana.
Sunana Argo.
Sunana.
Right.
Okay.
And then we've got...
I'm Jody Dickmeyer, second-year resident.
Mm-hmm.
I'm Sherry Hamilton, nurse practitioner.
Hey David, this is Paul Daly. I'm here as well.
Hey Paul, good to hear your voice.
So as you can see, we've got a full house today.
Sounds like it. Okay, well.
Quite a few people online, too.
Okay, yeah, I see that. That's great. Well, welcome everyone online, and hello to everyone in Kansas City. Oops. And okay. So while you glimpse my disclaimer slide, I want to express my appreciation to Paul and Jay for inviting me to speak on urticaria again this year. Last year was my debut performance, and it's really a pleasure. And again, I want to credit Jay and Paul for their efforts to move this forward. And this is such an incredible service to allergists in North America, and I'm really grateful to be part of it. There's 3 learning objectives. That after participation, you'll be able to describe an evidence-based and cost-effective approach to diagnosis and management of patients with chronic urticaria angioedema. Number 2, that you'll be able to identify patients with physical urticaria angioedema syndromes. And number 3, that you'll be able to recognize patients with refractory chronic urticaria angioedema. Urticaria angioedema occurs in all age groups. It's more common in women aged 35 to 60. This is a condition that is frequently a vexing condition for both patients and patient and healthcare provider. Management entails realistic expectations and regular use of pharmacotherapy, so that without regular use of pharmacotherapy, patients will continue to experience symptoms that interfere with their quality of life. So it's important that patients are adherent with therapy, and this is something I'll get back to. Urticaria may be defined as swelling that involves the superficial dermis. It's usually generalized. Lesions are pruritic and have a duration of minutes to hours. And here's an example of a patient who experienced generalized urticaria. As an inpatient, you can notice based on the right upper portion of the picture here, the hospital gown, a patient who experienced generalized urticaria after infusion of a beta-lactam antibiotic. Angioedema may be defined as swelling that in the deeper dermis. It's usually localized. It can be mildly pruritic, but also may have a burning quality. And individual lesions have a duration of hours. This is a picture of a patient with angioedema of her right distal upper extremity after cold water immersion. This is a patient with cold urticaria angioedema.
Oh.
And I'm going to present information on urticaria angioedema in a case-based fashion. So here we have our first case, and these are people, or patients, I should say, who actually exist. I don't make this up. So KF is a 38-year-old anthropologist with a 3-month history of daily episodes of pruritus and hives. Hives were described as erythematous, ranging in size from pencil eraser to quarter, with a duration of less than 24 hours. KF experienced 1 episode of periorbital swelling, but she denied episodes of throat constriction. She was hive-free while taking oral steroids, but then relapsed after that was suspended. And a month before I saw her, an oral contraceptive was suspended without improvement. And her medications were an over-the-counter antihistamine taken as needed. So here we have our first opportunity for interaction, and perhaps I could ask Jody and Sunana and Teva and Nikita and Monica to collaborate on an answer here. The best evidence-based management recommendation for KF is A, a rotational food elimination diet, which is likely to be associated with benefit. B, avoidance of tartrazine, yellow dye number 5, which is commonly associated with this condition. C, extensive diagnostic evaluation is warranted to identify an etiology, including C1 inhibitor level and functional assay. Or D, she should be told that she has a condition that is likely idiopathic.
So what do you think?
What do you think?
We think D.
D. Everybody thinks D. They're probably not going to be able to figure out what's causing it.
Okay, well, D is the right answer. She should be told that she has a condition that's likely idiopathic. The universe of urticaria angioedema can be categorized as acute or chronic based on whether symptoms have been present on a continuous or intermittent basis for 6 weeks. After 6 weeks, patients graduate to having chronic urticaria. Prior to 6 weeks, patients are classified as having acute urticaria, and in many cases we can identify a cause. In the overwhelming proportion of patients with chronic urticaria angioedema, we do not identify a cause. This is a classic series published in the British Journal of Dermatology in 1969, and a large series, 554 cases. And you can see that in most cases, such as is the case with our KF, our anthropologist, most patients have both urticaria and angioedema. And in some instances, urticaria or angioedema are present alone, and about a third total. But in 2/3 of cases, in this series, patients had both urticaria and angioedema. And what you'll read in a lot of review articles that you encounter is that chronic urticaria angioedema is idiopathic in about 80% of cases. And I believe this is where that estimate comes from, because the etiology was described as being quote-unquote unknown in 79% of cases. And here is a table clipped from this paper published in 1969 in which you can see the total number of cases and the 21% roughly cases, 21% of cases for which an etiology was identified. And if you focus in on the cases for which a cause was identified, it seems to me that the 80% estimate is actually an underestimate of the proportion of patients for whom we can really identify an underlying cause for chronic urticaria angioedema.
Isn't that because we don't really know what the cause of physical urticaria and cholinergic urticaria are? Just because we give them a name doesn't mean we know the cause.
Right. So, you know, we don't know what, I mean, the authors didn't elaborate on, for instance, what allergic urticaria was in these patients.
Those are probably the ones that they had.
I don't know, you're right, I don't know whether identifying dermatographia in a patient with chronic urticaria angioedema counts as identifying a cause. So what do we want to know when we encounter a patient such as KF? First of all, we want to know details about the urticaria angioedema. What sensation accompanies the appearance of these lesions, and what's the size of a lesion? I usually ask patients to identify this in terms of coin sizes, of a dime, quarter, $50 or larger. Sometimes they're the size of a pencil eraser, and in patients with cholinergic urticaria, they're pinpoint lesions. How long do they last? Is there a residual bruise after the lesions fade? A duration longer than 24 hours and residual bruising can be interpreted as signs suggestive for the presence of a vasculitic process as opposed to a garden variety urticaria. What factors provoke episodes? And frequently these are major clues for the presence of a physical urticaria angioedema condition. For instance, the occurrence of areas of swelling in a delayed fashion at sites of pressure, provocation of swelling in association with cold, etc. And the presence of associated fever, arthralgias, recent exposure, travel, may be signs that, in fact, there is an underlying cause and may prompt a more extensive laboratory investigation. You can also approach these lesions with, I use a glass slide, or you can use a Scotch glass if you prefer, as shown here. But what you want to, this is called dioscopy, so that by occluding blood flow locally to the site of the urticaria lesion, you can make the lesion blanch. Because the reason that these lesions appear is due to increased vascular permeability. So you can make the lesion pretty much disappear or blanch with pressure. When the lesion doesn't blanch, it suggests that that there's more to the lesion being there than increased vascular permeability, such as damage to the blood vessel, which is vasculitis. So here's opportunity number 2 for some interaction. So Monica, Nikita, Sunana, Teva, Jody, what would you order were you seeing KF for evaluation in terms of laboratory testing?
What do you think?
EBC and sed rate.
Okay, you get a sedimentation rate.
TSH, thyroid antibodies, LFT.
Yeah.
Anything else?
Chronic urticaria index.
A chronic urticaria index. Okay, we'll talk about that.
Would anybody get like a large panel of IgEs to foods?
No.
Everybody's shaking their head no.
Okay. Well, this is what I got with KF. I got a CBC with differential, a chemistry panel, a urinalysis, and a sedimentation rate. And I also got a TSH and antimicrosomal antithyroglobulin antibodies. A few years ago. I don't know that I would order as many tests now, but that's what I got. And, they were all within normal limits or unremarkable, all these tests. Guidelines recommend limited testing for patients with chronic urticaria unless there are symptoms or signs which suggest the presence of an underlying condition. So the Joint Council of Allergy Asthmanology in the most recently published guidelines, which were more than a decade ago, and as Jay mentioned in introducing me, these guidelines are being updated now, and the manuscript is being submitted for publication shortly. So the 2000 guidelines recommended a CBC, urinalysis, sedimentation rate, liver enzymes, and TSH, as well as thyroid autoantibodies in selected cases. Skin or serologic testing is not indicated. So I guess I'm pretty much in compliance with these guidelines based on what I ordered. As are you. We'll get back to the chronic urticaria index. And the European guidelines recommended only a CBC and sedimentation rate or C-reactive protein. Those guidelines are more recent, from 3 years ago. So we carried out a study here at the Cleveland Clinic, which was published last year, in which we asked this question: what proportion of laboratory tests obtained in patients with chronic urticaria angioedema actually lead to a change in management and in outcomes of care? This was a retrospective analysis of a random sample of adult patients with chronic urticaria angioedema seen here from 2001 to 2009. We identified 356 cases which fulfilled our criteria of having chronic urticaria angioedema according to the billing code shown here, and patients who had their laboratory tests ordered at Cleveland Clinic. 1,872 laboratory tests in total were ordered for these 356 patients. 319 of these, 17%, were abnormal, and 30 patients, 8.4%, underwent additional testing based on initial laboratory findings. So a mean of 6.0 tests were obtained for each patient. Abnormalities were commonly seen in complete blood counts, roughly a third, and in complete metabolic panels, almost 10%. The majority of abnormal CBCs had a slightly elevated or reduced neutrophil count and or slightly elevated eosinophil count, for which no further workup was pursued. Most abnormal metabolic panels involved slightly abnormal transaminase levels, for which further workup wasn't pursued. Sedimentation rate was elevated in about 1 in 6 cases in which this was ordered. So how many improved based on a change in management directed by a laboratory result? 1 patient. She had a history of hypothyroidism and improved with an increase in dose of levothyroxine from 88 to 150 micrograms. Previously, her chronic urticaria was well controlled on 175 micrograms of levothyroxine daily, and 3 months prior to evaluation with us, she had an MI, and her levothyroxine dose was reduced from 175 to 88 micrograms daily based on a low TSH. Her urticaria worsened and persisted despite regular antihistamines. She had elevated levels of antithyroid antibodies, and after titration of her thyroid hormone, her urticaria resolved and she was able to taper off antihistamines. So our findings support recent recommendations to limit laboratory evaluation in patients with chronic urticaria angioedema, so the diagnostic evaluation can serve to rule out an underlying cause for chronic urticaria angioedema in a cost-effective manner, while in most cases providing what could be called a reassurance value for patients. So unless your patient has an element of his or her history that suggests the potential for exposure, or there are signs on physical exam which would imply that perhaps there's an underlying condition that's present. In other words, unless there's something unusual, the laboratory evaluation tends not to be associated with improved patient care outcomes. So our laboratory tests were within normal limits or unremarkable for KF. And I think I have 1 slide here, 2 slides on pathogenesis. The next is a picture. But this is an inflammatory process initiated by mast cell degranulation. On biopsy, we see perivascular infiltrate that surrounds small venules within the superficial and deep venular plexus. CD4 positive lymphocytes and monocytes are prominent. There's virtually no B cells. PMNs and or eosinophils may be present. The pathogenesis entails cellular recruitment via release of cytokines, chemotactic factors, with activation and recruitment of adhesion molecules on migrating cells as well as endothelial cells. And here we see typical Histopathology on biopsy, it's a lymphomononuclear infiltrate with no signs of vasculitis. Foods are commonly suspected, foods and at times food additives, but rarely confirmed as causal or underlying factors. However, rarely, food additives have been described in the literature as provoking not only urticaria angioedema, but also other adverse reactions. And this can be suspected when symptoms that occur after food beverage consumption are observed, some but not all the time, suggesting that the reaction occurs only when an additive is present. For instance, a patient may have, moving out of the realm of urticaria angioedema, a patient may have bronchospasm. A patient with moderate to severe persistent asthma may have bronchospasm after consuming dried apricots, but may be able to eat an apricot without adverse reaction, implying that the sulfite content of the dried fruit is the factor associated with the episode, and that this patient doesn't have an allergy to eating apricots. Aspirin and aspirin-type drugs may provoke a flare of urticaria angioedema in about a third of patients, and in a higher percentage of patients during an active phase of their urticaria angioedema, such that patients like KF should be advised to avoid aspirin or aspirin-type drugs, taking acetaminophen as an equally efficacious analgesic in order to reduce a potential provoking, perpetuating factor for ongoing episodes of urticaria angioedema. Angioedema may be categorized as histamine or bradykinin mediated, and as shown here, ACE inhibitor provoked angioedema is in the same category as C1 inhibitor deficiency in terms of its pathogenesis, in the sense that it is bradykinin mediated. So although this isn't a presentation on C1 inhibitor deficiency, I did want to include mention of angioedema related to ACE inhibitors. ACE inhibitors were introduced more than 30 years ago for management of hypertension, congestive heart failure, and ACE inhibition, angiotensin-converting enzyme, is also a kinase. And when angiotensin-converting enzyme is inhibited, it leads to slowed enzymatic degradation of bradykinin. This occurs, that is angioedema on ACE inhibitor treatment, about 0.1 to 0.5% of patients. It's more common in African Americans, smokers, and women, less common in diabetics. It remains the most common cause of acute angioedema seen in emergency departments in North America, and about 1 in 5 cases may be life-threatening. The management entails suspension of the ACE inhibitor, as this is a class-specific effect. Patients should be instructed to avoid all ACE inhibitors in that continuing administration or substituting one ACE for another may lead to more severe episodes. Although not shown on the slide, I should add that there is a risk as well for ongoing angioedema when patients with ACE inhibitors are switched to angiotensin receptor blockers. A meta-analysis published in the Annals of Allergy Immunology several years ago, the risk for this ranged from 2 to 7, as I recall, 2 to 17%. Most patients who are switched to angiotensin receptor blockers can tolerate these drugs without experiencing angioedema. So the decision to switch a patient to an angiotensin receptor blocker has to be approached carefully from the standpoint of the potential for benefit related to ongoing angiotensin inhibition versus the potential for harm, that is the risk for recurrence of angioedema, and should involve the patient in terms of the patient expressing his or her values and preferences in the medical decision-making process.
Hey, Dave?
Yes.
Is there a metabolic or genetic marker for an increased risk of that issue, of that problem?
You mean the angiotensin receptor blockers?
Or just the
ACE inhibitors. Jay, I'm sorry, are you referring to the angiotensin receptor blockers?
Either one, ACE inhibitors or ARBs. Is there any way of predicting who's at increased risk of experiencing that adverse event?
Not that I'm aware of, no. Well, the patients who've had angioedema related to ACE inhibitors in the past are at elevated risk were they to take an angiotensin receptor blocker. Beyond that, other than for the demographic factors that are shown on the slide, I'm not familiar with any other risk factors that can be identified a priori.
No single nucleotide polymorphisms?
Not that I'm aware of. Moreover, there is some suggestive evidence implying that patients who lack the potential for other kinases to contribute once ACE inhibition occurs, that such patients would be at elevated risk. But there's no test that can be done per se to assess that. I should add that the mechanism regarding angioedema related to angiotensin receptor blockers, which has been reported independent of patients being switched from an ACE inhibitor, is not well understood.
Okay.
So now we're moving on to physical urticaria angioedema, and a number of the syndromes are described here, and I'm going to show you some illustrations. This is a patient with dermatographia. This is, some reports, the most common physical urticaria angioedema syndrome encountered. Estimates vary, but about 3 to 5% of the general population has this. Many of them don't present to healthcare providers because of this, and can be discovered, as we're all, and we've all experienced this, can be discovered when they come to see someone like me or Jay or Paul, etc., and undergo skin testing, and we learn that the skin testing is uninterpretable because they react based on the capacity of the skin to urticate in response to trauma or stroking. This is a patient with cholinergic urticaria after an exercise challenge, and this is cholinergic urticaria is related to abnormal handling of acetylcholine in the skin. These patients tend to form characteristic pinpoint hives. They'll tell you that their pruritus and urticaria are triggered by hot showers, hot, humid weather. This is a patient, very rare physical urticaria angioedema syndrome, whom I saw about a year ago. It's a patient with aquagenic urticaria who had an appropriate challenge study and then developed lesions which actually were very similar to the lesions of cholinergic urticaria. They were pinpoint hives that were intensely pruritic. And here's a patient with delayed pressure urticaria angioedema. There are protocols for each of these syndromes in terms of challenges to provoke lesions that will confirm the diagnosis. And the protocol we have here entails patients carrying a gym bag that has 15 pounds of weights, and they carry it with a strap across their shoulder, and 15 pounds for 15 minutes, and then we carry out an immediate reading here. But actually, in the old days, when I was more compulsive than I am now, I used to have patients come back for a second visit and show up at 8 o'clock in the morning, and then come back and see me at about 4:30 at the end of the day, so I could do a delayed reading myself. But now I think patients are sufficiently competent to do this on their own. So I usually tell them before they go to bed that night, which is usually around 7 to 10 hours after the stimulus is applied, tell them to look at their shoulder and then to look at their shoulder the following morning when they wake up. And what I used to get over the phone, I used to have them call me the next day or even overnight and leave me a voicemail message and let me know what their shoulder looked like. And before I gave them more specific instructions, which I gave to this patient, I used to get either fruit or sports metaphors. So it was usually there's a plum on my shoulder, there's a tennis ball on my shoulder, and that would be it. But now I tell people to please measure the area that develops, and you can see this patient was pretty compulsive because he sent me this picture over the internet, and you can see that he has the ruler on the right panel here. But you can see that an area develops. I mean, I've taken this challenge myself, and you walk around with the weight suspended over your shoulder, and your shoulder's kind of sore for a few minutes afterwards, and there's a red mark where the strap was, but then it goes away. But the people who have this condition, after it goes away, later, hours later, will develop an area of angioedema that's tender. Were such an area to be biopsied, it would look a lot like a late-phase cutaneous allergic reaction. It's inflammatory. This condition is important to identify because of the delayed nature of the swelling. Most patients don't put it together. But if you question them, they'll tell you that after they sit on a bench, that hours later their buttocks may be sore and they may develop what they would call a quote-unquote big hive. Same thing when they stand on their feet for long periods of time. If they use their hands with a tool like a screwdriver, their hands will swell afterwards. This condition tends, at least the angioedema component, tends not to be as antihistamine responsive. It is corticosteroid responsive, but you want to avoid giving corticosteroids to these patients as much as you can. So these patients may be refractory in the sense of being antihistamine resistant.
Do they respond to bradykinin antagonists?
That I don't know. I don't know that anybody has investigated that. There is an uncontrolled series which describes the utility of sulfasalazine in the management of delayed pressure urticaria angioedema. I have a number of patients on sulfasalazine. Okay, so again, this is the final page of the medical boards. And in terms of the medical boards, this is something you should be aware of. A substantial proportion of patients, 40 to 50%, in some studies 50 to 60%, will have an IgG autoantibody that can be detected that's directed against an IgE receptor. And when this was initially described, it was thought that such patients had evidence for an autoimmune disease and that such patients may be candidates for immunosuppressive therapy. But to make a long story short, subsequent studies showed that these patients really didn't differ substantially from patients who had no evidence of such antibodies in terms of their response to pharmacotherapeutic interventions and the clinical course of their urticaria angioedema, although some subsequent reports suggested that these patients tended to have a more recalcitrant course. So in terms of pharmacotherapy, H1 antihistamines are the preferred first-line therapy for patients with chronic urticaria angioedema. Numerous randomized controlled trials done over the last half-century have demonstrated the efficacy of H1 antihistamines in patients with chronic urticaria angioedema. As you all know, the first-generation agents are associated with risk for sedation and prominent anticholinergic effects. So second-generation agents, which are equally efficacious and are better tolerated, are preferred for first-line therapy. So the good news is that there is high-quality evidence supporting the therapeutic utility of H1 antihistamines, leading to a strong recommendation for their use as first-line therapy. The not-so-good news is that this is where the high-quality evidence ends. There are no other agents that can be endorsed with a strong recommendation based on the current evidence in the literature. So what do you do when conventional doses of H1 antihistamines aren't associated with efficacy? Well, here's a study from Bulgaria published in the Journal of Allergy and Clinical Immunology in 2010, in which 80 patients with chronic urticaria were randomized for double-blind treatment with levocetirizine or desloratadine, 40 in each group. Treatment was started at the FDA-approved dose of 5 milligrams. That's 5 milligrams of levocetirizine or desloratadine, and then the dose was increased on a weekly basis to 10 milligrams and then 20 milligrams in patients whose relief of symptoms was incomplete. Ultimately, there was a crossover or drug switch to 20 milligrams of the opposite drug if urticaria angioedema wasn't well controlled. In this study, about 75% of patients were responders to higher than conventional antihistamine doses. So these data provide support for the practice of dose advancement of antihistamines in patients whose condition is not well controlled on conventional FDA-approved doses. This is a study from the Mayo Clinic published in 1985 in which 50 patients with chronic idiopathic urticaria were randomized in a crossover design to doxepin 10 milligrams 3 times a day or diphenhydramine 25 milligrams 3 times a day. As you can see, total clearing of pruritus and urticarial lesions occurred in 43% of patients while receiving doxepin and in only 5% while receiving diphenhydramine. Partial or total control of pruritus and hives was observed in 74% of the patients receiving doxepin and in only 10% of those receiving diphenhydramine. Surprisingly, doxepin induced markedly less sedation, 22%, than diphenhydramine, which was 46%. So based on the greater potency of doxepin, compared with diphenhydramine, it's 775 times more potent on a molar basis. This study also provides evidence, in this case indirect evidence, supporting antihistamine dose advancement for patients not well controlled on conventional antihistamine doses. What about H2 antihistamines? Well, it turns out the evidence is tough to interpret. Small numbers of patients have been studied. Different H1 antihistamines were used. The dose of H2 antihistamine varied, and most of this is cimetidine data. In some studies, superior efficacy was described. In other studies, there was no advantage. Also, confounding the interpretation of this literature is that in a number of studies, hydroxyzine was combined with cimetidine for the H1-H2 combination group in the study, and there's a drug-drug interaction such that when you take hydroxyzine with cimetidine, the blood level of hydroxyzine is increased. So basically, what you're doing when you combine hydroxyzine and cimetidine is you're hiking the dose of the hydroxyzine, which makes it difficult to interpret in a comparator group where patients are getting the same dose. However, because of the favorable safety profile of H2 antihistamines, and now there's not as much of a cost issue, many allergists will prescribe H1 combined with H2 with the understanding that, at least on an anecdotal level, there are some patients that will improve, and about 15%, that's 15% of histamine receptors peripherally are H2. What about anti-leukotrienes? Well, compared with some of the other agents that I'm about to talk about, there's a substantial safety advantage. And again, the literature is mixed in terms of studies in which favorable findings versus no advantage was shown. Data suggest a salutary effect is more likely in patients with aspirin-exacerbated urticaria angioedema or who have physical urticaria angioedema, particularly patients with delayed pressure urticaria angioedema. There's an Israeli report, for instance, demonstrating the utility of montelukast in patients with delayed pressure urticaria angioedema. And in one report from Jonathan Bernstein, patients who have a positive autologous serum skin test. What about cortical steroids? Here's a study from, it's an emergency department study in which 43 adult patients with acute urticaria were given diphenhydramine intramuscularly, then hydroxyzine 25 milligrams every 4 to 8 hours, and they were randomized to prednisone 20 milligrams twice a day or placebo twice a day. And what you see is there was a statistically significant difference in terms of more rapid resolution and improvement in pruritus score, although the placebo group also didn't do so bad. So what we will advocate in the practice parameter for urticaria angioedema is a stepwise approach such that first-line treatment is a second-generation antihistamine. As I mentioned, there's high-quality evidence leading to a strong recommendation for use of antihistamines, and the second-generation agents are preferred because of their more favorable safety profile. If that alone is not sufficient to achieve control of urticaria angioedema, the healthcare provider has a number of other options, which would include dose advancement and/or adding an H2 antihistamine and/or adding an anti-leukotriene drug. Beyond that, so that would be step 2. Beyond that, step 3 and step 4 are shown here, such that anti-inflammatory agents can be considered, including colchicine, sulfasalazine, hydroxychloroquine, or dapsone. And if that's not sufficient, then so-called immunomodulators, including cyclosporin, omalizumab, etc., can be entertained. There aren't many agents which have been studied in randomized controlled trials. There is one randomized controlled trial in which patients with refractory urticaria angioedema were randomized to hydroxychloroquine or placebo for 12 weeks. As indicated near the top of the slide, the dose of hydroxychloroquine used in the study is not described in the manuscript from Australia. Patients were maintained on other medications, again, and either had hydroxychloroquine or placebo added for 12 weeks. The study did find statistically significant differences with regards to quality of life scores, and there was a trend for benefit that was greater in patients randomized to hydroxychloroquine compared with placebo in terms of reductions in medication and urticaria scores. Cyclosporin is the best studied agent, called alternative or steroid-sparing agent in patients with chronic urticaria angioedema. There are 3 randomized controlled trials in which patients were randomized to either cyclosporin or cetirizine was the comparator at doses of either 10 or 20 milligrams a day. Methodologic shortcomings were recognized in each study, and we used the GRADE approach, which Jay is familiar with, and I think we on the task force have all become increasingly familiar with, to critically appraise the evidence in this area. And again, I've said this before already pertaining to something else, but to make a long story as short as I can, because of the methodological shortcomings in these studies and the fact that it's unclear whether the potential for desirable effects significantly outweighs the risk for undesirable effects, we we judge the evidence supporting cyclosporin administration to be low, leading to a weak recommendation based on current evidence. It doesn't mean that you shouldn't prescribe cyclosporin. What it does mean is that you should carefully consider, from an individualized standpoint, whether the potential for benefit exceeds the potential for harm and the burden associated with treatment, which may include, for instance, frequent blood draws in the case of cyclosporin, and invite the patient to voice their values and preferences and participate in the decision-making process. There are ongoing trials, as I think you're aware, investigating the therapeutic utility of omalizumab. This is a paper published in the Journal of Allergy and Clinical Immunology in 2008. This is an uncontrolled study, an open trial. In this study, 7 of 12 patients who received omalizumab achieved complete symptom resolution. And this is, as I understand it, undergoing further study in phase 3 trials. And there really are unmet needs in the management of patients with chronic refractory urticaria angioedema. In a number of studies, this can be up to 40 or even 50% of patients who are seen who don't respond optimally to antihistamines advanced as required and as tolerated. So I have one other case here in the remaining minutes. Now we're going to talk about KP. A 35-year-old dental hygienist referred to rule out penicillin allergy as a cause for hives. She was hospitalized 3 months earlier for necrotizing fasciitis and toxic shock syndrome. She had a pruritus and erythema during a course of a beta-lactam, but received no interval antibiotics, and she required a blood transfusion. She'd had daily episodes of urticaria for 4 weeks prior to this visit. She described her lesions as having a duration of less than 24 hours. She denied fever, change in appetite, other constitutional symptoms. She had 1 episode of tongue swelling, 2 episodes of periorbital swelling. On physical exam, she had no urticaria. She was dermatographic. She was taking an oral contraceptive daily, MS-Contin and diphenhydramine, and diphenhydramine was PRN. And in looking through her labs 6 weeks earlier, she had modest elevation in both her ALT and AST. Her penicillin skin testing was negative, and she tolerated Pen-VK 250 milligrams without adverse reaction. And she was told that her risk for IgE-mediated reaction to penicillin or other beta-lactams wasn't elevated compared to the general population. She was advised to minimize use of MS-Contin, as that can be another factor in addition to aspirin and aspirin-type drugs that can worsen the course of urticaria angioedema. And we told her to take fexofenadine 180 milligrams daily. And in the interest of time, I'll just move through this. These are the labs that we obtained for in evaluating KP. We also got hepatitis serologies and CMV titers in terms of her blood transfusion. And her labs were within normal limits or unremarkable with the exception of her CMV, including her CMV IgM. So we interpreted KP's course of urticaria angioedema, and again, this is acute urticaria angioedema because it was 4 weeks. Our interpretation was that this was most likely a case of CMV acquired during blood transfusion. And at return visit, she was hive-free on fexofenadine 180 milligrams daily, no other remarkable interval history or physical exam findings, and we tapered her down on fexofenadine, and she did well. So there are cases in which we identify a cause. So what does it all mean? I'm going to offer some concluding remarks and then would open it up for questions, comments. This is clipped from the dermatology literature. This is, 170 years ago? Urticaria is one of the few cutaneous eruptions which can be traced directly to its source, so you can see we've come a long way in 170 years. This is my final slide. The caption here reads, "Nothing serious, just a case of hives." And I want to close by making the point that coming full circle, this is something I mentioned at the beginning of my talk that this tends to be a vexing condition for patient and physician, but actually, on the upside, this is a condition for which we as board-certified allergy immunology physicians, we can do a lot to help people. Even though we can't provide the answer to the question that many people with this condition walk through the door with, what's causing my hives, what's causing my swelling, even though we can't provide the answer to that, in the overwhelming majority of cases, this condition can be improved, and if not, well controlled. And there's a lot that we can do to help these people, not only from the standpoint of giving them what hopefully will be an effective regimen of medications that should be well tolerated with minimal or no untoward effects, but also giving them peace of mind and giving them appropriate information regarding the nature of their condition. Many patients come to us at the Cleveland Clinic with chronic urticaria angioedema with a variety of misconceptions and are not well informed. So again, I think that I hope my presentation has been helpful, and you know, when you see patients with this condition, Monica, Nikita, Teva, Sunana, Jody, I hope you bear this in mind and that you approach these patients from the standpoint of, wow, you know, here's a patient with chronic urticaria. This is a patient who I'm going to be able to help a lot. So thank you for your attention.
Thank you, Dave. That was fantastic. I'm going to go ahead and make us the presenter again so you can see us.
I look forward to it.
Here we are. See us?
Yeah, I do.
So we're still here, and we've certainly been paying attention. This has been a fantastic presentation. I had a question before everybody else pops in. A lot of patients come in and they want to know if it was their hives are due to foods or drugs. They've had it for many months. And how long can hives due to a food or a drug last before you'd say that it's probably not the food or the drug? If it lasts longer than a certain amount of time, does that kind of give it away?
Well, I think the answer is separate for a food or a drug. I don't think that any of these patients will awaken with hives in the morning or have hives in the evening, hours after they've consumed food items. And I usually interpret such a history as essentially ruling out a role for foods as a provoking or perpetuating factor. I mean, I think if for patients with chronic urticaria angioedema, I would expect them, well, first of all, statistically, it's much less likely they're going to have more than one food as the culprit. Mm-hmm. So they would need to have hives in association with eating that particular food or food group, if you will, if you want to broaden it. And that would be going on for 6 weeks or longer before they see me, and it's pretty unusual. With regards to a drug, I want to say that in his, I'm trying to reel in the memory, that dermatographia, for instance, can persist for weeks to months after. And I think our former mentor, Ken Matthews, described that. Right. Dermatographia can persist for, I want to say, months in association with adverse reaction to penicillin.
I've seen that, yeah.
So that's a little different than food, so I'd separate them out. So I think that the drug reaction can go on for some time.
Questions from the group, anyone?
So just to clarify, is that after the discontinuation of the drug?
Yes.
So months?
Months. Okay. I mean, that's, I don't see that very often, but it has been described. And generally, a reaction to a medication, in many instances, the medication is suspended. You remove the stimulus for the immune response, and the immune response fades, and the drug reaction of course, it can be hastened by administration of antihistamine and cortical steroid, which is given in many instances. So I don't think it's typical. In fact, it isn't typical for the drug reaction to persist, but it has been described, and it may occur.
Yeah, in pediatrics, we see a lot more hives during the summer months.
Usually acute urticaria lasts about 5 days or so. And we usually tell patients that it's associated with like a viral infection, maybe enterovirus. It's almost like a viral exanthem. Do you have any thoughts about that?
No, other than just having observed, similar, patients who have such eruptions. There are no other thoughts that I have about that per se. I'm not sure what your. I think it would be unusual for such cases to progress to chronic urticaria, but it may.
Right.
I think that the only other thought I would have is that I suspect that may be one of the observations that led to the 6-week rule coming into effect. That by the time 6 weeks rolls around, it's generally not a viral exanthem. It's something else.
It would have done something. It would have progressed or gone away by the end of the 6 weeks. And fortuitously, there's a 6-week waiting time to get into our allergy clinic, and they usually make the appointment when the hives first show up. So a lot of them come in and they say, I had hives 6 weeks ago. What was that? And they want us to somehow tell them. It always seemed a little bit strange.
I think it'd be easy to turn this around and say, well, the good news is,
fine
in such cases, so that's good for you. We have same-day appointments here, so there's not a 6-week.
Yeah, you're fortunate. Dr. Jacobs, did you have a question? I've got you unmuted. Well, Dr. Jacobs wrote in the chat box, if omalizumab gains an FDA indication for CIU, wondering where you think it will fall in the treatment algorithm. I was in a patient room, so my apologies if you already discussed it. So he's in practice.
Great. So I think I'm not speaking now on behalf of the task force. I'm speaking on my own behalf in responding to the question. But I would, I would say that if it is approved by the FDA, it would imply that the evidence is there supporting its efficacy. I would need more information in terms of safety and other issues, including duration of treatment. But it would seem to me that omalizumab would not come in until after step 2, which would entail what I described previously in terms of combination H1, H2 antihistamine and particularly dose advancement of antihistamines. There are a lot of patients who come to our center referred for what ostensibly is refractory urticaria angioedema who haven't had their antihistamine medications dose advanced accordingly. So I would say that for patients with antihistamine-resistant urticaria angioedema, which I would define as patients whose urticaria angioedema is not controlled with antihistamine medication advanced as tolerated, as necessary to control the condition. Those patients with antihistamine-resistant urticaria angioedema, for those patients there are unmet needs. There's no question. And we're going to need more information, particularly regarding the details of the clinical trials in which the efficacy of omalizumab would be established, leading to FDA approval, in order to place this, in terms of step 3 versus step 4 in the step care approach for urticaria angioedema. Again, the other agents there being agents such as colchicine, sulfasalazine, hydroxychloroquine, etc., dapsone, each of which, as anti-inflammatory agents, have their own issues with regards to the potential for harm and burden associated with treatment as opposed to potential for benefit, and each of which is not supported by strong evidence. I mean, we're omalizumab to move forward. Were there to be studies demonstrating its efficacy, then it would take and take a prominent role among the agents prescribed for patients with antihistamine-resistant urticaria angioedema, in the sense that it would stand out as an agent perhaps supported by strong evidence.
Yeah, one advantage that we have is that they usually come in on too low a dose of antihistamine, and we just increase it, and then it goes away, and we get credit, which is really nice. Don't forget doxepin, too. In terms of these other step 3 agents, we have a sheet or a form that lists all of the agents, the potential side effects, and the possible benefits that we show to the patients if they've failed steps 1 and 2 so that they can participate in making that decision. And a lot of times when they see those things, they're like, well, you know, the hives aren't that bad. I think I'll just stick with what I got. So sometimes that can be an effective approach.
So Jay, you have what is called an information guide.
Exactly.
That's great.
Yeah, maybe we all should share that.
So the patients are able to it's like a cafeteria selection.
Yeah, these are the different options now. Are these things that you might want to try next? And you know, most of the time they look at all of that and they say, you know, hives aren't really that bad. I think we'll just kind of keep doing what we're doing, and then that's okay. We're going to have to stop here. It's been really great and informative. That was a fantastic presentation. We really appreciate it, Dave.
Thank you. You're too. It's my pleasure to be a part of this, and again, I want to congratulate you on the success of the conference's online allergy series.
Right. So hopefully everybody will stay cool and not too itchy, because the heat certainly does make everyone feel a little bit itchier. So we're going to stop there. This is Conferences Online Allergy from Children's Mercy Hospitals and Clinics in Kansas City. Have a great week, everyone, and thank you, Dave, and we'll see you next time. Take care.
Sounds great.
Bye. Bye-bye, Dave.
Bye.
This has been an ACAAI production. To learn more about Conferences Online Allergy or the American College of Allergy, Asthma, and Immunology, go to acaai.org. See you next time.